Hello, this is Dr. Lisa Thomas. I'm a faculty in the Orvis School of Nursing. The purpose of this presentation is to talk about a couple of important things. Firstly, we're going to talk about therapeutic relationships, which are the relationships that we develop with patients in the clinical setting. And then we're going to talk about the flip of that, which is professional boundaries between nurses and patients and kind of what is our role and what isn't our role in the clinical setting. And then we are going to talk just a little bit about social media and how social media plays into and does not play into the way that you interact with patients. So first, let's talk about what kind of relationships exist. We might talk about professional relationships. Professional relationships are ones that you have at work. So that's very much like the relationship that your faculty have with you as a clinical student or as a student in the program. And then you've got your social relationships, and these are the relationships that you have with friends. Obviously, these are going to be a lot more casual. And then what we have with patients are called more therapeutic relationships. And so, how do you know the difference? So, a therapeutic relationship has interaction that is focused on helping the client or the patient. It's not about you. And that's, I think, the most important thing that helps you know the difference is that the relationship is solely focused on assisting the patient, assisting the client to achieve a goal. Also, a therapeutic relationship is one that requires the special skills of the nurse that is providing care. It focuses on the client and it is something that is purposeful and goal oriented and has a time limit. And so those are things that really distinguish and differentiate a therapeutic relationship. It's purposeful, it's goal-oriented, and it's time-limited. Where in contrast, a social relationship really can be about either person. And often social relationships ebb and flow, where in sometimes it's about one person, sometimes it's about the other, but neither party is responsible for the well-being of the other, typically. The focus tends to be on the relationship rather than on another person, and the relationship is casual, it's reciprocal, and it doesn't have a built-in time limit. So a longer definition, a professional therapeutic relationship is one that allows the healthcare professional to apply their professional skills, their knowledge, their abilities, and their expertise toward meeting the goals of the patient. So, developing therapeutic relationships with patients is one of the most important skills a nurse can develop. And so therapeutic relationships are based on a variety of things, but among of them, and chiefly so, is trust. And so without trust that you do what you say you're going to do, that you say what you mean, without trust, we don't have the ability to move forward in a therapeutic relationship. Genuine interest in the success of the outcome for the patient or the person that you're taking care of. Acceptance, and acceptance is huge in healthcare. You note that this does not necessarily mean acceptance of every behavior, but it's acceptance of differences and acceptance of what it is that makes us different from other people. And so then having a positive regard for people. You may sometimes hear people say things that can be judgmental. And the positive regard is viewing every person based on their strengths, which involves and requires a significant amount of self-awareness. Because we cannot take good care of other people until we really understand ourselves and our own biases and what it is that we bring to a situation. And then in any therapeutic relationship, we use ourself therapeutically. And so that is one of those things that also waxes and wanes and ebbs and flows is how much you insert yourself into a care environment. So, in a therapeutic nurse patient relationship, the nurse is the person who's responsible for initiating that relationship and directing it toward the client needs. And so, that relationship again is purposeful, it's goal directed, it has very defined boundaries that are structured to meet the needs of the patient, and so not the needs of the healthcare worker. So, therapeutic relationships really move through three phases. And so we're going to talk a little bit about those. But those three phases is so orientation, and then the working phase, and then the termination phase. And we remember that every professional relationship has a termination phase. And so we'll talk a little bit more about that. But the orientation phase is when the nurse and the patient first meet. We establish roles, we clarify expectations, we identify problems, and we build trust. During this beginning, getting to know you orientation phase of a relationship, because if we don't build that trust, we're not going to be able to achieve our goals. So then we move to the working phase. And so the working phase, generally in healthcare and in nursing, is we're going to work with the patient, we're going to establish mutual goals because we might have a goal for the patient that may not be that patient's goals. And unless these are mutually set and mutually agreed upon, we're not going to generally achieve what we want to achieve. And then we have the termination phase of a relationship. And so the termination may be at the end of your clinical day. It may be at the end of your shift. It may be at the end of that patient's hospital stay. But the termination phase, if you keep in your mind that this begins with the first encounter. So when you set out that the relationship has a time limit, and so then this ends when the relationship ends or when the goal directed purpose for the relationship ends. And so in the realm of student nurses, I think one of the most difficult things is that you will meet a whole lot of really amazing people during your clinical rotations while you're in the hospital, while you're taking care of patients. And it's important to keep in mind that these people, while they may be wonderful people, are not your friends. We don't go to the hospital to take care of patients to make friends. And so if you keep that in mind, and so what does that mean? Does it mean if your patient's going to be lonely after you leave, that you can go and visit them after clinical? And the answer is no. And sometimes it's sad because your patients might be very lonely occasionally, may not have people who come to visit them, or you've developed a really nice bond with that patient. However, that relationship exists only while you are on the clock or during clinical. And so we don't go back to the clinical setting ever to see a patient after our shift has ended, particularly in the student nurse role, because to be in a patient care setting, you have to have a faculty with you on site personally um, accountable for your presence. And so, for that reason, you can't be in the clinical setting, but also it just gets confusing for the patients and confusing for everybody involved. So, therapeutic communication has several different domains. And so, a lot of it is verbal, it's the words that we use to speak. And then there's the context in which that happens, and so the environment in which that communication occurs. And so it may include the physical, social, emotional, cultural environment, but always the context is something that is professional. The context is not going and meeting for coffee, going and getting a drink, is the context of a therapeutic relationship always exists within the confines of a healthcare setting. So then we have nonverbal communication, which is behavior that accompanies your verbal content. And so we can say something and seem and sound very therapeutic, but the way we say it might be very different. And so in nonverbal communication, we talk a lot about eye contact, facial expression, tone of voice, your speed and your hesitations in your speech, and being aware of cultural differences in these. In our American culture, eye contact is viewed as imperative, that you don't talk to somebody without looking them in the eye. But in some cultures, it's actually viewed as threatening. So it's very important that we learn about cultures and how do different cultures deal with things like contact and touch and eye contact and facial expression. And we want to be sure that we're congruent, that what we say and what we do mean the same thing. So we talk a lot about boundaries. And so think about, and most of us know that this person who, whenever they talk to you or they speak, they get right up in your bubble. And so be careful to be very mindful of boundaries and space. Now, in nursing, do we get into people's personal bubble? Yeah, every day, all the time. We have to get in close to help people move, which is one of the most uncomfortable things for new nursing students, is being really in somebody's space, because that personal zone, which is that really almost an intimate zone closer than 18 inches, is closer than most people get with their friends and their family. But we get into people's space a lot in healthcare. But when we're just talking to a person, we try to stay in that personal zone or outside of it. So our social zone. And so think about when you're talking with people in a social setting or in a work setting or in a business setting, and they get up kind of within a foot or two of you, most people start getting a little bit squirrely and a little bit heebie-jeebie because somebody is in their space. And think about that's what we do with patients all the time. So a little bit about touching. For a lot of people and in a lot of settings, touch is something that's comforting and it's supportive, but it also can be an invasion of people's intimate and personal space. And so it's important that we be mindful of that because, again, remember, we're not there for us, we're there for the patient. Now, do we sometimes have to touch people? Sure. Sometimes we even have to touch people when they don't want us to touch them. So the least we can do is tell them that we're going to touch them. Okay, I'm going to take your dressing off now. You're going to feel me touching you. I'm going to touch you. I'm going to clean your back, let's say. So we need to be able to evaluate whether your patient perceives that touch as positive or threatening or wanted or unwanted. And so we never assume that touching a patient is acceptable, though we sometimes have to do that. But we want to be very mindful of what types of touch we use. So the types of touch that we use in the hospital and in the healthcare setting really are professional and functional touching. So when we're doing procedures, which often are very intimate and involve private parts of people's bodies, but it's professional and functional touch. And the best way to pull that off is to be professional and functional and confident. If somebody is going to be touching your private areas of your body, you don't want them to be tentative and hesitant about that. It's just a part of what they do. Most of what we do in healthcare is social touch. So greetings, handshake. And then there's kinds of touch that really doesn't have a place in the patient care setting. So the first of these, friendship and warmth, is really a gray area in patient care. Might you put an arm around a patient's shoulder? Probably rarely. You might occasionally. It depends on the relationship you have with the patient. But it's not the norm by any stretch. And then, so the next two types of touch, love and intimacy, this is things you save for your friends, your family, your kids, your spouse. But this is not the kind of touch we use with patients. And then sexual touch, we'll just say no, just no. And I don't think we need to really belabor that one, but just no. And so listening, how do we know when we are actively listening to a patient? Well, so that means refraining from other mental activities and that we're really paying attention to what the patient says. And that goes right along with active observation because that goes along with how they say it. And so we're looking at their nonverbal actions. And so what we're looking for this is congruency between what they say and how they say it. So if a patient is telling you, for example, oh, yeah, I'm having a great day and I feel wonderful, but they're tearful and look afraid and they don't make eye contact, it makes us want to ask some more questions about, what is really going on here. So often in healthcare, we want to be sure that we're focusing on concrete messages. So we want our messages to be specific and clear because these are going to elicit the most accurate response from the patient. So one of the things that we see a lot, and especially if somebody goes to the doctor, if people come in to the emergency room even, a common question that I see that drives me insane is, what brings you here today? Well, what does bring me here today? It might be a car. I might have walked. Might be that my mom took me, or my daughter, or my spouse. So ask a question that actually asks the question you want an answer to. So instead of saying, what brings you here? What health symptoms caused you to come to the hospital today? And then the person you're talking to actually knows what it is you're trying to get at. And then we talk about therapeutic communication techniques. And so the big five, we talk about exploring, focusing, restating, reflecting, and making observations. So this flashes back to the communications course that you took as a prerequisite to this program. But so exploring, when somebody gives us an answer, we might follow up. So tell me more about that. Okay, so all right, so tell me what that means to you. And then focusing. We do this a lot with patients as we ask questions, and conversations tend to go off in a direction that really isn't where either we or the patient really needs to go. So we want to bring it back to, okay, so I'm going to give you your medication now. So tell me, would you like one pill or two right now? So restating, we want to clarify that we understand and be sure that we actually do understand what the patient is telling us. And then reflecting. I'm hearing you say that this is upsetting. I hear that you're upset. And then making observations. You tell me that you're having a great day, but yet it seems that you're very sad today. How can I help? So non-therapeutic techniques, and unfortunately, you'll see these a lot in the healthcare setting, but advising. Telling people, and do we in healthcare tell people what to do? Of course we do. Absolutely. But sometimes that can also be excessive. Agreeing with fixed false beliefs. So we see this a lot in our elderly population who are perhaps have dementia, are confused. And so where our role really should be to gently reorient a patient to gently bring them back to where we are rather than agreeing, oh, yeah, she thinks she's on a cruise ship. Let's see, I'll be the captain and you be the first mate. There's really no place for that, and we don't need to do that. But we can gently reorient people. And false reassurance. And this is one of the things that we see in healthcare because it's the thing we want to do. We want to tell people, oh, it's going to be okay. You'll be okay. You're going to be all right. Do we know that? No, we don't know if they're going to be okay. We don't know if everything's going to be all right. So, how can we respond instead? We might say, wow, I'm very sorry you have to go through this today. I'm going to do everything I can to make this have a good outcome for you or your loved one. And nonverbal communication. And always remember, it's not what you say, it's the way you say it. So we need to be mindful of facial expression and body language and vocal cues and eye contact and how we use silence. Patients are going to tell you things that are going to just kind of shock you to your core occasionally. And so now is a good time to really kind of work on that neutral and accepting facial expression. Same thing with your body language. We communicate with body language more than we realize. So a person sitting back with their arms folded says a lot about that they're closed. They aren't open to your communication, where a person who leans slightly forward and makes eye contact is somebody that we feel is interested in us. And then we have directive and non-directive communication. We try to the extent possible in healthcare is we ask open-ended questions because we want to collect information. Tell me about your mobility. Tell me about how you get around at home. Would be a good example of open-ended, non-directive communication. But occasionally we do have to be directive in our response. In a crisis or in an emergency situation, I might say to a patient, I need you to sit down. I need to know, are you having pain? If a patient tells me they have chest pain, my communication is going to get very directive immediately because I'm going to say, okay, do you have pain in your chest? Does it go anywhere? Does it radiate to your arm? Do you feel sick to your stomach? Are you feeling nauseous? Are you sweaty? Do you feel like you're having a hard time catching your breath? I'm going to ask a lot of really quick yes/no questions because I need to get at, are they having chest pain because they ate too much hot sauce and they have indigestion? Are they having chest pain because they're having a heart attack? And so there's a time to use both of these. And so now we're going to talk about the flip side of therapeutic relationships is we're going to talk about professional boundaries because we want to have a therapeutic relationship with our patient, but we also need to have boundaries. So what are these professional boundaries? So these are the space between the nurse's power and the client's vulnerability. And you may be thinking, oh my gosh, I don't have power. I'm a level 1 nursing student. I haven't even really started nursing school yet. I know nothing. How could I be perceived as having power? And I guarantee you, the first minute that you walk into a patient care setting, your patient is lying horizontal with their rear end hanging out the back of a hospital gown, and you're standing with a uniform on. And they don't know how much you know. And so you definitely do have power. And so that boundary provides the structure that really encapsulates that relationship. And it allows for a safe relationship that focuses on the needs of the patient or the client. So our patients are vulnerable. Again, they very often rely on us for everything. They rely on us to bring them food. They rely on us to help them with their hygiene. They rely on us for the very air that they breathe very often in a clinical setting. And we, as healthcare workers, are in a great position of authority and power because of the knowledge and the skills that we bring to that setting. And so the two of these really create a power differential between the nurse's power and the client's vulnerability. So it's very important that we be mindful of this all the time when we're taking care of patients, is that there is a power differential. And it's just inherent in the relationship and it's inherent in the setting. And we need to be very, very cautious of how we operate within that. So we talk about professional boundaries, and I like this picture partly because I love the beach and it makes me feel like I'm at the beach, but also we talk about professional boundaries as something that ebbs and flows a lot. And there's not a really, really clear line in the sand because sometimes we are going to assert and insert a little bit more of ourselves into a relationship than we might in other situations. And so this next video comes from the National Council of State Boards of Nursing and does a really good job talking about professional boundaries in healthcare.
Mary, a home health nurse, has been providing care to Dorothy for more than 6 months. The two of them have enjoyed pleasant conversations and discovered several mutual interests. Dorothy genuinely likes Mary and is grateful for the excellent care she's provided. Their friendly relationship has always remained on a professional level, until today, when Dorothy overhears Mary telling a friend about her financial problems. When Mary ends her phone call, Dorothy offers to lend her money. Hesitant at first, Mary eventually accepts a loan, and in doing so, commits a serious violation of professional boundaries. Nurses inspire confidence in their patients by treating them professionally, objectively, and ethically. Patients and their families expect nurses to always act in their best interests and to adhere to the standards of professional conduct while maintaining a respectful and professional relationship. But nurses have a type of authority and influence that comes from their professional position. Their specialized knowledge and skills, as well as access to private information, make the patient vulnerable. The inherent difference in this relationship requires boundaries to help nurses establish and maintain limits in their professional interactions with patients. By using professional judgment to determine and stay within appropriate boundaries, nurses can meet their patients' needs. On the other hand, nurses who put their personal needs ahead of their patients' needs will cross over these professional boundaries. These types of behaviors violate laws and regulations that are designed to protect the public, as well as meet the standards of professional conduct. Every nurse-patient relationship can be depicted on a continuum of professional behavior. At the center of the continuum is what is commonly referred to as the therapeutic nurse-patient relationship. This relationship protects the patient's dignity, autonomy, and privacy. Under-involvement by the nurse is characterized by distancing, disinterest, and neglect. These types of behaviors create an imbalance in the nurse-patient relationship. At the other end of the continuum is over-involvement. Almost all professional boundary crossings and violations occur at this end of the continuum. The continuum serves as a frame of reference for helping nurses evaluate their own and their colleagues' interactions with patients. Unfortunately, while some boundaries are clear-cut, others may not be quite so easy to recognize at first. Let's take a look at the different types of over-involvement. We'll use a few examples to help us illustrate these behaviors. Boundary crossings, which are sometimes called boundary drifts, are brief excursions across professional lines of behavior. The behavior is often inadvertent, but sometimes the behavior can be purposeful and is used to meet a perceived therapeutic need. For example, Jack is concerned that his patient Lucy is becoming discouraged with her progress in physical therapy. Jack knows that Lucy is a fan of his alma mater's basketball team, so he gives Lucy a sweatshirt to wear during therapy. This is an example of an intentional boundary crossing with a specific therapeutic purpose in mind. Boundary crossings can sometimes occur in a therapeutic nurse-patient relationship, but these incidents should be evaluated by the nurse for potential consequences and implications to a patient, because boundary crossings can sometimes lead to a boundary violation. Boundary violations result when there's confusion between the needs of the nurse and those of the patient. These violations are characterized by excessive personal disclosure by the nurse, secrecy, or even a reversal of roles. Let's say that Jack secretively gives Lucy a sweatshirt and tells her they should go to a game together wearing their matching sweatshirts. In this case, Jack is putting his own needs and desires before the patient's. The difference is context. In the second case, the act of presenting the exact same gift becomes a boundary violation. Mary's acceptance of a loan from Dorothy is another example of a boundary violation. By allowing Dorothy to learn of her financial issues, Mary disclosed too much information about her personal life. When she accepted a loan from her patient, Mary placed her personal gain ahead of her patient's best interests. Professional sexual misconduct is an extreme form of boundary violation. It includes any behavior that is seductive, sexually demeaning, harassing, or reasonably interpreted as sexual by a patient. Professional sexual misconduct creates a breach of trust, and this is an extremely serious violation of the nurse's professional responsibility to a patient. Violations of the Nurse Practice Act are addressed by boards of nursing. Depending on the laws and regulations of the jurisdiction, as well as the severity and context of the boundary crossing or violation, consequences may range from verbal warnings to license suspension or revocation. So, how can we identify potential boundary crossings and violations before they happen? Nurses who display one or more of the following behaviors should examine their patient relationships for possible boundary crossings or violations. Excessive self-disclosure, secretive behavior, special treatment, flirtation, or overprotective behavior. Any of these behaviors may indicate a shift from the therapeutic nurse-patient relationship to over-involvement with the patient. Once a nurse becomes over-involved in the patient's world, the professional relationship is betrayed. Many of these behaviors may have a reasonable explanation. However, if a pattern emerges, it's time to stop and evaluate the behavior and possibly talk with a colleague or mentor. The earlier a nurse evaluates behaviors and seeks help, the greater the chances of returning to the therapeutic nurse-patient relationship. Take the case of Katie, a nurse caring for a late-stage cancer patient, Cindy. Cindy's husband, Joe, is having trouble coping with his wife's illness. Wanting to comfort Joe, Katie has drifted from conversations with him outside his wife's room to having coffee with him in the hospital cafeteria. Now, Joe is calling Katie at home and posting comments on social media saying she's the only person who really understands what he's going through. Uncertain what to make of the situation, Katie talks to her nurse manager, who helps Katie understand that while her intentions are good, her actions constitute inappropriate over-involvement with a patient's family. Because she is open to assessing her professional relationships and sharing her concerns with her manager, Katie is able to return to patient-centered care before a boundary violation occurs. If Katie hadn't recognized the warning signs and talked to her manager, the crossing could have escalated to a boundary violation. Boundary crossings can happen to any nurse. The key to avoiding them is continual alertness, self-evaluation, and emphasis on the patient's best interests. In respecting professional boundaries, nurses protect their patients, themselves, and the profession.
So in that video, they talk about some different breaches of trust. But who's harmed by that? And the answer is really everybody involved. The client is harmed because there's a breach of trust, there's embarrassment, can cause compromised care. The nurse very well may be disciplined for crossing a boundary, particularly when this involves inappropriate personal relationships with patients or patients' family members. It ruins careers and it ruins lives, but it also very negatively affects the profession of nursing because nursing is viewed as being the most trustworthy profession by the US Gallup poll in every year except for 2001. After 9/11, we lost out to firefighters for a brief time, but nurses are viewed as trusting and trustful by the public. And so when nurses violate the boundaries of the healthcare setting, it erodes the confidence that the public has in us, and that there's a lot of states that have started to criminalize these behaviors. So it's important that we remain ever vigilant and aware of these. So we ask ourselves, what are our limits? And so good rules to live by is that we limit physical contact to that which is therapeutic. We don't need to get in people's space and touch them unless it has a function in a healthcare setting. And we already talked about our social contact is on duty. And that doesn't mean that we might not be very social with our patients while we're taking care of them. But at the end of the day, at 7 p.m., at 7 a.m., we go in and we say, goodbye. It's been a privilege taking care of you today. I look forward to seeing you when I come back at 7 a.m. tomorrow. Or this is my third day and you'll probably be home by the time I come back to work. So I wish you all the best. And we limit that and we end that relationship there. This seems to go without saying, but we don't ever have financial or legal dealings with our patients. Oh my goodness. And we limit our disclosure to superficial information. And this again is a very gray area. A patient might ask me, if I have children. And sure, I very likely will answer, but it depends on the patient. A patient's asking me, hey, do you have kids? I'll be like, yeah, I have 2 daughters. They're amazing. But a different patient asks me, hey, do you have any little girls? I'm probably not going to tell them very much. So self-disclosure, very superficial. And again, it's all about context. Context is everything when we're working with patients. So let's just address the question. Could it happen? What if you have an attraction for a patient, for a client? Generally, this happens the other way around, where occasionally a patient will become somewhat fixated and infatuated by a specific nurse. And in that situation, we just kind of move around assignments. There was a patient a while back, a colleague of mine who worked at a local hospital, who had a patient who was calling him at work all the time and was showing up. And that's more often the case. But might you feel attracted to a patient? You're going to meet amazing people taking care of them in the hospital. Most important thing is that we don't act on that. If you've met somebody in a hospital situation where that power differential exists, where you are providing care, that person is off limits as a person with whom you may ever have a relationship, especially a romantic relationship. But particularly I mean, you may not even, it's probably not even appropriate to have a friend relationship with somebody that you met in the context of the patient care setting. So if you find yourself in that situation, obviously the first thing you do is that you do not go talk about the patient. Is that you do not go talk about that with the patient. Hey, yeah, so I'm going to have another nurse come take care of you because really I think that you're awfully cute. And, I'm just thinking that's not good. No, we can just change out care of that patient to another nurse. So we do want to make sure that we talk about these feelings. So whether it's either a clinical instructor or a trusted colleague. And so by that same token, if you have a patient that's acting inappropriately toward you, same thing. Discuss that with somebody so that that situation can be addressed so that you are not put in an uncomfortable place. And so finally, good thing to live by is the golden rules of patient care and professional boundaries. And if you keep these two in mind, it'll keep you out of trouble pretty reliably. The main one is don't do or say anything in public or in private that you would not want to be documented in the patient record. So I would say don't say anything to a patient that you wouldn't want to read about in a progress note. And trust your gut. If you're in an uncomfortable situation, get out of it. Do what you need to do to get out of that situation. So, we're going to take just a moment to talk a little bit about social media. Social media has become such a rampant issue in healthcare and in society that we need to have very, very clear direction on how do we interact with social media while we're in a patient care setting. And so this next video also comes from the National Council of State Boards of Nursing, and they do a really good job talking about the implication and impact of social media on nurses and in nursing.
Emily was a nursing student in a pediatrics rotation. She cared for Tommy, a 5-year-old patient who was recently diagnosed with type 1 diabetes. Tommy was going home soon, so she took a cell phone picture of him to remember him by. That evening, she posted his picture on her Facebook page, commenting how brave he was when he got his insulin injections. 2 days later, Emily was called into her dean's office. A nurse from the hospital had seen the photo and caption and reported them to hospital officials. Emily was informed that her actions were a breach of her patient's confidentiality and a violation of federal privacy laws. Even though Emily had an excellent record as a student nurse and had only the best intentions in her post, she was expelled from her nursing program, and the program was barred from using the pediatrics unit for their students.
Hi, I'm Kelly, a staff nurse here at the hospital. If you use social media properly, what happened to Emily will never happen to you. Nurses are increasingly utilizing social media not only for personal use, but also as a way to foster professional connections and timely communications with patients and their families. Though social media used inappropriately can result in disclosing too much patient information and violating the rights to privacy and confidentiality of information. This is what happened to Emily. Healthcare organizations typically have clear policies governing employee use of electronic and social media in the workplace. It is outside the workplace, however, where policies are often less clear and the potential for inappropriate use of social media is greatly increased. Effective nurse-patient relationships are built on trust. A cornerstone of that trust is patient privacy, which is a key part of a patient's expectation of being treated with dignity and respect. Any patient information that a nurse has access to during the course of treatment must be safeguarded. With very limited exceptions, such information may only be disclosed to other members of the healthcare team for the purpose of providing care for the patient. Improper use of social media by nurses may violate state and federal laws, including the Health Insurance Portability and Accountability Act, or HIPAA, which was enacted to further protect patient privacy. Additionally, inappropriate uses of electronic and social media may be reported to your Board of Nursing, resulting in possible disciplinary action for unprofessional or unethical conduct, breach of confidentiality, or other infractions. While it's true that some intentional or malicious misuses of social media do occur, the majority of inappropriate disclosures or postings are unintentional. Usually, they're the result of the mistaken belief that the communication or posting is private, and accessible only by the intended recipient, that content deleted from the site is no longer accessible, or that it is acceptable to discuss or refer to a patient in a posting if they're not identified by name. By being cautious and alert to potential or improper uses of social media, you can avoid inadvertently disclosing confidential information concerning your patients. Remember, you have an ethical and legal obligation to maintain patient privacy at all times. This means that you should never take photos or videos of patients using your cell phones or other personal devices. Be sure to follow employer policies for taking photos or videos of patients for treatments or other permissible purposes by using employer-provided devices. Even experienced nurses should be vigilant about avoiding serious violations of patient confidentiality, as Jason learned.
Jason has been a nurse for 12 years and is working in hospice care. One of his current patients, Maria, maintains a hospital-sponsored online page to keep her family and friends updated on her battle with cancer. One day, she posted something about her depression and the difficulty of finding effective treatments for her physical pain. Jason saw the post and responded by writing a comment to Maria. He wrote that he understood her last few days had been difficult, and he was hopeful that the new medication, along with the increased dose of morphine, would provide some needed relief. The next day, Jason ran into a friend who said she saw his post. She said Maria was an old family friend, was sad to hear of her condition, and asked Jason how long he thought Maria had left. Now fully realizing the implications of what he had done, he immediately went home and tried to remove his post, but was unable to do so. Besides, even if he had been successful in removing it, it may have already been copied by others and posted elsewhere. At his next visit with Maria, Jason told her what had happened and apologized. Jason then self-reported his breach of patient confidentiality to his board of nursing and is awaiting the board's decision concerning any disciplinary action.
Jason learned the importance of carefully considering the full implications of posting any information about patients on any website, including hospital-sponsored sites. It may at times be appropriate for nurses to express empathy and support for patients on a website, but they must be careful not to disclose private patient information. Inappropriate use of social media can derail someone's dream to be a nurse, as it did for Emily. But even for experienced nurses like Jason, who have exceptional work histories, inappropriate use of social media can and does happen. Remember, increased access to communication through social media does not change a healthcare professional's responsibility to protect patient information. In fact, it actually makes it easier to inappropriately share information. By carefully following standardized guidelines, healthcare professionals can responsibly use social media to improve the coordination of patient care. For more information, please visit the website of the National Council of State Boards of Nursing.
I hope you enjoyed that video, and with that, that ends this presentation. Please, again, if you have questions, please be sure to reach out to your clinical faculty or your clinical coordinator. If that is me, then please absolutely reach out to me. If it's not, please reach out to somebody. Remember, we want to be able to answer your questions if you run into them. And so have a great rest of your day.